Thank you, Virginie, and hello, everyone. So the goal of this first session is to give you an overview of the technology behind the programming algorithms controlling our SCS systems. So we will see that with the WaveWriter Alpha, we can put in place different neural targeting strategies to optimize the SCS therapy delivery. And first, I would like to introduce the reason why we came with the concept of programming our SCS system using algorithms such as Illumina 3D for paresthesia-based SCS. And in fact, the quick answer is that the programming algorithm is an assistance, making the therapy control simple but also intuitive, while using advanced programming functions, allowing, for example, to truly shape the electric field under our electrodes to deliver the stimulation at the right target. So talking about targeting then, when it comes to conventional SCS, the goal is to generate paresthesia over the pain area using low frequency above perception threshold. So our neural target here is well known. We want to engage the dorsal column. And more precisely, we want to catch the sensory fibers corresponding to the pain area. So with this in mind, we have developed two complementary pieces of technology. A battery with multiple sources of current first that we call MICC, which is a technology improving the precision and the stability of our therapy. And on the top of MICC, we have our programming algorithm, Illumina 3D, which is truly optimizing the control of our advanced battery technology. So this MICC technology, which stands for multiple independent current control, can be seen as the engine powering our IPGs. And in short, with MICC, every single contact of our lead are controlled by a dedicated source of current. So we will see that if we compare MICC to a conventional single source system, we can see quite large differences. If we consider two contacts first, controlled by a single source stimulator, we could here generate three different points of stimulation. With MICC, because we can control the fractionalization of the current allocated on each contact with a 1% increment, it means that then we have 100 possible points of stimulation available. And the difference is even more visible as we increase the number of contacts. With 4, a single source system would offer 9 different points of stimulation, when MICC would truly open an accessible area under the electrodes with 10,000 possible configurations. So thanks to the flexibility of MICC, we can then precisely adjust our targeting when a single source system may be slightly off target and not specific to the area to treat. But then the clinical endpoint of MICC is probably the most interesting aspect. By playing with the current fractionalization, we can progressively steer our point of stimulation under our electrodes from the left to the right, for example. And as a result, the paresthesia coverage will also slightly move and slide to the right side as well. So thanks to this flexibility, we can really work on advanced customization of the therapy to be specific to the area we want to treat. But then, if we consider the programming of MICC, we can here foresee a potential limit. In manual mode or in manual programming, we can probably spend a lot of time to control the steering of the currents between all the contacts of interest. So that's why on the top of MICC, we developed a programming algorithm, Illumina 3D, that can be seen as a driver assistance in a way. So Illumina 3D will assist you to make the best use of MICC as the electrode configurations are automatically generated in real time by the algorithm. So Illumina 3D is in fact based on a 3D finite element model that incorporates spine anatomy and characteristics such as the CSF thickness at the different spine level, but also electrical tissue characteristics of the various elements of the thoracic spine. The model is also customized to each patient as we integrate their electrode placements. We are in fact considering the mediolateral and rostropodal placement of the electrodes, their spacing, the potential contact offsets between different leads, and all is based basically on the fluoroscopy of the patient. And finally, we have a modelization of the electric field and its associated axonal response in the dorsal column for a given electrode configuration. So then, how does it look like to program with an algorithm? In fact, the user simply inputs a desired point of stimulation using the programming interface. It's what we call the point and click programming. The algorithm then calculates in the background using our SCS model the optimal electrode configuration to activate the dorsal columns right under the selected point. So for the user, it means that the anode cathode configuration and the current distribution are generated automatically. We can then navigate the point of stimulation step by step to match the paresthesia coverage with the pain area, and the algorithm here will adjust the electrode configuration in real time. So it makes the exploration of the electrodes much more intuitive thanks to this automatic real-time programming. But Illumina 3D is in fact designed for paresthesia-based SCS. And today, we also have available to us sub-perception SCS with major clinical differences. We are using today higher frequency, higher energy at amplitude below perception threshold. And for sub-perception today, the mechanism of action is still not identified, although current hypothesis suggests that it is probably mediated more in the dorsal horns. So based on the understanding we have today of sub-perception therapy, together with the clinical learning using sub-perception, we have developed a dedicated targeting algorithm named Contour, with the intent to preferentially modulate dorsal horn circuits. And in fact, there are several aspects we took into consideration in the development of this new algorithm. The first one is probably more practical. When working in sub-perception, we observe that the therapy initiation can be challenging. In the PROCO study, for example, where a conventional 8mm bipole was used, which is a focal electrode configuration, it was observed that the optimal bipole placement could vary pretty broadly from the bottom of T8 to the top of T11 to treat low back and leg pain. And because of the washing time of sub-perception therapy, which can be up to 1 or 2 days, when you initiate the therapy, you don't know if you are at the right spot or not. So it's a kind of trial and error programming there. And in the end, the optimization of the sub-perception therapy can really take time. So our new Contour algorithm generates a large and broad field shape that is creating a kind of blanket of stimulation over the spine. And here, the current is precisely adjusted on every contact to generate such a field shape. The intent of this field design is to basically optimize the targeting in sub-perception and to have a more efficient therapy delivery. Contour is also probably more robust and a more robust configuration to maintain the therapy on the long term in front of potential minor limb migration, for example. Also, A second aspect we took into consideration in the development of contour is more the mechanistic challenge of subperception. So what is basically the neural target for subperception? And as you can see on this slide, several mechanisms of action have been proposed over the last 10 years. But hopefully we are also progressively learning as well. And preclinical efforts have ruled out and ruled in several prospective hypotheses. And we have today mounting evidence suggesting that subperception may preferentially and more directly engage the dorsal horn over the traditional dorsal column. Basically, this hypothesis is also supported by preclinical work showing the direct synaptic activation of the superficial layers of dorsal horn when using subperception modality. A particularly interesting target that has emerged to us based on those observations are a population of superficial inhibitory interneurons represented in yellow on this slide. And something of interest to us is that these inhibitory interneurons are distinctively oriented rostrocaudally. Their dendrites and terminals also end segmentally. So they have a really specific structure. And per neural engineering principle, these properties make this neuron particularly susceptible to certain types of electrodes geometries, certain types of electric fields. So maybe we can take advantage of those properties to design a new field shape. And that's what we've done basically. And to test this hypothesis, we have built a simplified model that captures the properties of those cells. And we were able then to simulate the response of those interneurons under several electrode configurations. When using a conventional 8mm bipole, the model predicts a mild and localized effect on the dorsal horns. So maybe we can do better than that. And in fact, the model predicts that certain types of electrode configurations, such as contour, having this distinctive uniformity under the electrodes, that can be also aligned more directly in the dorsal horn, could produce a broader dorsal horn effect and a stronger dorsal horn effect as well. So in short, based on the hypothesis that the mechanism of action of subperception is driven by dorsal horn elements, we developed and adapted our model with a new target, and we have tried new field design to optimize the therapy delivery and to be more specific to this potential target. And that's how we have designed this new contour field, optimized for subperception targeting with this extended and uniform field shape under our electrodes. So to conclude, we believe that neural targeting is crucial to optimize the SCS therapy delivery. So it's all about how can we optimize the interface with the right target to deliver the therapy. Illumina 3D is basically designed to precisely target the dorsal columns in paresthesia-based therapy. And on the other hand, Contour is engineered to preferentially engage the dorsal horn in subperception. So neural targeting is one aspect of SCS, but there's also other considerations, such as the neural dose we deliver through our electrodes.